Hi, everybody. Good afternoon. Good afternoon, everybody. Welcome back. We'll start the afternoon with PJ Mattress. She's a clinical nurse specialist for pain, and she's going to talk to us on what resources we have here at Providence in regards to pain. PJ, you're a co-host now.
Awesome. Thank you so much. And can you just confirm, do you see the next slide, or do you just see one slide?
We see the slide.
Just one slide.
Yes, just one slide.
Perfect. Well, thank you all, and welcome to Providence Healthcare. My name is PJ Matras, and I'm the clinical nurse specialist for pain management, who I work primarily on the acute pain service. Okay, well, there we go. And I'm starting with this shameless plug. We have this Pacific Pain Forum. It used to be called the Interdisciplinary Pain Education Day, and it has grown, and hopefully that it will continue to grow. So I encourage you, if you are interested in pain, maybe this is something that could be of interest to you. I hope to see some of you on April 28th next year. So my role, the majority of it is a clinical practice. I do see most of the patients on the acute pain service who have had surgery and have either have a PCA, perineural, epidural, ketamine, or lidocaine. Those with complex pain, especially those coming for surgery. And of course, we do see patients in consult as well. Now, I always say, if you have a complex pain patient, please consider calling me. And, oftentimes we can troubleshoot with orders you have and discuss. If you do want the acute pain service to come in and actually write orders on your patient, that usually is a doctor-to-doctor consult, but do consider calling me. I think we can get through a lot together. So my office, though, that is my local. I am rarely in my office. Usually by the afternoon, I can make it back to my office, but that is my cell phone. And please don't be shy. Do consider calling me. So I always try to, it seems to be working. So when we used to be able to meet in person, I want to discuss, and I want you to really kind of think and self-reflect on some of these statements. And when you read the statement, decide maybe, is there anything true about this statement, or false or likely to be false? And what are the beliefs behind it? But really, more importantly, if you have these beliefs, how will that impact your care of the patients and the care the patient receives? So the one is, and I struggle with this one, because a lot of people, when you hear that opioids are the best treatment type for all types of severe pain, and if you think about that, and even when you're, in your practice, I know I always tell this, I think it's a funny story. My brother would kill me. But back in the day, my brother's a musician in Winnipeg, and he used to be married to an emerge nurse. And sure enough, he had kidney stones. And as I don't know, he was in his early 30s. And so he actually did go to the emergency room with horrible pain. And in those days, they were giving morphine. So they gave him some morphine IV. And he said it did nothing for the pain, but he could not stay awake. And he said he could swear that he could hear the nurses from the door saying, check this guy out. That's what 8 out of 10 looks like. And he's like, and, in those days, they tried to convince him to take an Indocid suppository. And of course, for those of you who know, Indocid is a non-steroidal anti-inflammatory. And first he thought, no, I'm not taking anything rectally. That's terrible. Well, by the morning, they convinced him to take this Indocid suppository. And after that, he was convinced that's the only way you take medications, because it actually really worked. And when you think about the cause of pain with kidney stones, inflammation is a huge part of it, and oftentimes can be way more effective than our opioids. For those of you coming to surgery, the other type of pain that I really think about a lot is, we do so many minimally invasive or laparoscopic procedures here. And I think a lot of patients are told, like, oh, it's minimally invasive, it's not going to be painful. And I always, whenever I'm explaining it to patients, I always make the surgeons look like they're submarine drivers, because I always do this. I'm like, so in order for them to see, they insufflate with a lot of CO2. Of course, they try to get as much out as they can, but often it stays. And that can cause and I always liken our bowels to a bunch of tangled up Christmas lights. And the gas can get in the nooks and crannies and cause a lot of discomfort. And if you know anybody, or for those of you coming for surgery, you'll know that oftentimes they complain of shoulder pain. And that shoulder pain is because, just a second there, sorry, I'm doing a presentation. So that gas pain could be, I'm sorry, it rises and it goes under the diaphragm, and it irritates the phrenic nerve. So what can you do? I always tell people that the opiates don't really work very well for that. And for these patients, if they have a PCA, and if they press it, it really doesn't do a whole lot. And in fact, it slows the bowels a little bit. So really what does work for that kind of insufflation pain is walking, gum chewing, anything that's going to promote the bowels to get moving. But certainly opioids really don't work very well for that. The other thing I think about is neuropathic pain. When you look at the levels of treatment, I think opioids are about the fourth line intervention. They're even below cannabinoids now. And when you think, if you actually meet somebody who's been on long-term opioids for, say, a diabetic neuropathy or any type of neuropathic pain, ask them, does it really help your pain? Most of them will say no, but it actually makes them feel less about the pain, like they concentrate on it less. And in those cases, we're really getting the centralized effects of the opioids, more of a side effect than the actual treatment with them. So really, when you're thinking about, sometimes opioids are just not the treatment, what type of pain are we treating? And is it amenable to opioids? Because not all pain is. And oftentimes what happens is these patients, we end up increasing the dosage, and it doesn't really seemingly help, but then the patients get a whole lot of the side effects. All right, now this is the one, it is my favorite, but I always say I have to stretch for this one, because though the statement is quite offensive, the order is for hydromorphone 1 to 2 PO sub-Q or IV. She requested to be given IV as it works better. She's just being manipulative. And I would like to say you're never going to hear this, or you're never going to think this, but I know that's not true. I do hear it more than a few times in a week. So I want you to think about this order. First of all, are you going to see this order? I guarantee it, you will see this. And so when you start thinking that the problem is with your patient, there's already something wrong already. This order is, when you think about sub-Q and IV, the parenteral routes, and sub-Q and IV are considered 100% bioavailable. So really all your reference materials, if you have any apps for equal analgesia, you will see in order to get the oral equivalent, you need to times by 3 to get the oral equivalent. But we see orders like this all the time. And oftentimes we really are teaching people that IV or sub-Q works better. Now, oftentimes I will say to you, and I do apologize, I'm unable to get the Slido with this, but do think if, can you give PO and IV at the same time? Or can you give PO and sub-Q at the same time? I will answer that. But we're going to just discover this. Usually what happens is, if you see an order like this, somebody will go in and give them 1 milligram PO. That doesn't really work. The next time they go in, and I always call it the nocebo effect, we have all the pomp and circumstance of a nurse coming in and giving an injection, so it must work better, and they're going to give 2 milligrams sub-Q. Now that 2 milligrams is the equivalent of 6 milligrams PO. Of course, they're not going to work the same. And now you've got the nocebo effect of a nurse coming in and giving an injection, so it has to be better. And the patients really believe it works better. But I always say it's dose related. And then think about yourself, because I really do think, I talk to general surgery residents, anesthesia residents, and really try to discover your own beliefs. Do you believe sub-Q or IV works better? Because that is going to implicate or have implications for your practice. So really do think about that. Then the other thing is, when you're talking about IV, I always think when I'm providing care in terms of red flags. So if this person, when you see an order like this for 1 to 2 IV, I would need a couple of tick boxes ticked in order to feel safe going in to give this. Because what is a usual starting dose for somebody opioid naive? And when I say opioid naive, that doesn't mean they've had an opioid 2 years ago, they had an emerge visit and they received, no, this is somebody who's on regular opioids. Everybody else is really considered opioid naive. They do not take opioids regularly. So 1 to 2 IV for somebody opioid naive, that would not be a safe order. A usual starting dose would be 0.1 to 0.3, 0.1 for our older adults, those who may be sensitive to opioids, 0.2 for, a usual starting dose. Maybe even we could argue up to 0.4. And the reason I think we see these orders is because people do look at equal analgesia tables, and you might receive up to this within a 4-hour period. But it is given in dribs and drabs. And what do we know? We know IV works within about 2 minutes, 1 to 5 minutes. So fentanyl is closer to the 1 minute. Hydromorphone is about 2 minutes, and morphine is about 5 minutes to start to feel the effects. But it peaks at about 15 to 30 minutes. For most patients, they don't feel anything after about 30 minutes. That is not dose related. The higher the dose does not last longer. So you're giving a higher dose, they're still only getting really good relief for about 15 minutes, or I'm sorry, about 30 minutes, 15 to 30 minutes, but most will say 30 minutes. So when you see orders for 1 to 2 IV Q2H, those are almost cruel orders because they are getting relief for 30 minutes and then there is nothing for another hour and a half until you can repeat that dose. So really, when you do look at these doses, do try to discover, do you really believe that parenteral routes work better? Because really, if they have an intact GI tract, if you are going in and providing them with any other pills, do consider giving PO. PO works just as fine as all the other routes. The difference is now sub-Q, I mean, some people will say it works right away, but I believe that that is the nocebo effect. For most of the reference materials, I've given you a larger 10 to 30 minutes, but most will say it's around 20 minutes for onset. The other issue comes in when you do have an order like that and you have trialed a PO dose and it didn't really work enough. And then all of a sudden, maybe an hour later, you go in and you're like, the only order available is sub-Q, so I'm going to go give them sub-Q. What happens is they are going to peak at about the same time. So it's about 90 minutes after your PO dose and about 60 minutes after your sub-Q. So if you've given the oral dose, 30 minutes later, now you've given a sub-Q dose, where are you an hour later? Right? You're off looking after other patients. So that is the most unsafe. We should never be giving PO and sub-Q at the same time, or even in the same kind of event. Historically in the paper world, we used to have a note that said, if not taking PO, you can give the sub-Q. But certainly those should not be given together. And now I kind of ask for you to think about, can you give IV and PO? Well, the answer is yes. So if you have somebody who has severe pain, the PO, that lengthened time in order for it to start working 30 minutes, 30 to 45 minutes, is going to feel like 7 hours, and that's excruciating. So you can give the IV, but you're using it, and your rationale and your critical thinking is because I am basing that on the onset and peak. So we know, like I said, with IV, its onset is within about 0 to 5 minutes, peaks at around 15 to 30 minutes. Oral starts working in about 30 minutes. So by the time that IV is going down and off, the PO is starting to work. So yes, if your patient is having severe pain, you absolutely can give IV and PO together, but not the PO and the sub-Q. So do consider, I've been on this soapbox for a long time, the sub-Q. Certainly nausea is not a reason to go sub-Q. We do know the parenteral routes of opioids is way more nauseating than the oral doses. Unless your patient is vomiting and is unable to take any of their other pills, or they have an NG, or they have a bowel obstruction, we really shouldn't be considering these parenteral routes. The IV is great for that pain, like I said, that is out of control. But what I encourage you to do is know your starting doses, because you will see orders like that that are way too high for opioid naive patients. That is just not acceptable. Okay, I think I went to town on that one. Hopefully I will have a whole new generation of people. This sub-Q is so tough. We really do get about 2 or 3 referrals a week, in that people just really believe that they can't take opioids orally. They can take all their other meds, and it is absolutely not their fault. We have taught them this. It is hard to unlearn that when you know that somebody comes in and it actually really does work for your pain. It is very difficult to try to unlearn that, and it is absolutely not patient driven. It is us, the people who are ordering it, those of us giving it, all of those things. So do consider, take that extra pause when you're giving a sub-Q. Should I be? All right, that's an uphill battle, I'm afraid. Okay, so this is another one. She's a known drug user, therefore she will always exaggerate her pain. And again, I wish this didn't exist, and I wish you didn't feel this. But when you're thinking about this, and the reason I kind of keep this exercise in this presentation is because I really have a commitment to myself and as to all of you. There was my history. I used to work in critical care, and then I got seconded to work as a pain educator. And then I thought, oh, I don't know if I want to work in pain for the rest of my life. And I went to the recovery room. And, I am going back probably close to a decade. I have been in nursing about 30 years. And so it was, and it doesn't really matter at the time, but there was a lady who was hit by a car, and she had some sort of shoulder injury. And so I was in the recovery room, and she, when she went in for her shoulder surgery, I could hear her screaming from coming out from the OR. You guys are idiots. You don't know what you're doing. Get me my phone. So she came into the recovery room, and it was a different hospital. And so I wasn't the nurse looking after this patient, but the nurse was giving as much as we could in those days. I think it was like every 2 minutes. Nothing was really working. And I really like to believe, and I say this all the time, that I don't believe I'm an expert in a lot of things, but I do believe I'm an expert when I really believe I can check my own beliefs and values at the door. When I come into work, I'm here to look after the person in front of me. And I do it in a way that aligns with my values. And so in this day, they asked me, okay, what do you think we should do? And so in those days, I said, well, maybe we need to go to the functional pain. She is yelling, pneumonia isn't, an option. And we had a young anesthesiologist who came by and said, you know what, I'm going to put in a nerve block. And they put in a nerve block, and her pain went to almost zero. And she was absolutely delightful. She was very sorry. It was us. We woefully and adequately, horribly treated her pain. She didn't develop trust. She didn't trust us. All of those things have an impact. And I said, I wanted to share this story, and I hope to share this story as long as I'm in a job like this, because even that day I got caught. That sometimes the behavior in front of me didn't allow us to explore, and we should have, and we owe a duty to our patients and those who trust us and who we serve to try to find something else. There's always something else we can do. So just really, I wish I had her name, because I think about her all the time. So it's just something to consider. So now we'll talk a little bit about opioid safety. This is what I am very, very passionate about. And I do this all the time. And unfortunately, we don't have Slido. My fault, nobody else's. But I do want to, as you're thinking about it, as I'm incessantly talking, what comes first in relation to opioids? Is it sedation or is it respiratory depression? I'm going to bet at least half of you. I mean, it seems, some months it's a little bit better, but about half of you are probably thinking, well, of course, it's respiratory depression. And our Cerner reinforces that because every time you give an opioid, it asks for a respiratory rate. But it is, in fact, sedation. Sedation will always precede respiratory depression in relation to opioids. There are other things where you might see it simultaneously, certainly dose-related. If somebody actually has an overdose, it might happen simultaneously. But for our opioid, sedation will always precede respiratory depression. And in fact, when you think if somebody is getting a little bit sedated, they're not taking nice deep breaths, their CO2 is probably going up. Usually what happens is their rest rate goes up before it drops. I will talk a little bit about that when I talk about on the PAUSE scale, which we do use here at Providence Healthcare. So then when you think, who is actually at risk for opioid-related respiratory depression? Now, as you're thinking, and hopefully, well, yes, somebody's probably going to say elderly for sure. You might be surprised to know when elderly in the literature is supported. Some might say with, what do you think, sleep apnea? Let's go here. So really, when you look at our list here, anybody, it always cracks me up. And in fact, I make myself laugh that, I find it offensive at 55, not that I'm just perilously close to 55. So that's considered elderly in relation to risk factors related to opioids. Obesity, a lot of this is looking for undiagnosed or untreated OSA, which again, we will talk a little bit more about. But really, when you look at this list, it really is almost everybody you are giving opioids to in the hospital. And of note that we do know that many people who develop opioid-induced ventilatory impairment have no identifiable risk factors. So really, we do need to take extra caution when we are providing opioids. So when are people, is there a time when we start opioids or talking about opioids that are more dangerous for patients? Well, yes, what we do know is that first 24 hours of starting an opioid. More importantly, so say in the surgical world or anywhere where say maybe somebody's had a bowel obstruction, you've gone from the parenteral route, now you're switching over to PO, that's a dangerous time. Anytime you're changing routes. The other part, the most dangerous time is that first 6 hours out of the recovery room. And I would extrapolate also the first 6 hours out of emerge. It's an area of high intensity as well as high stimulation. A lot of times, certainly in the PACU, part of the usual routine is every 15 minutes going in and saying, hey, it's time to wake up. So oftentimes, and their pain, they've been receiving opioids as well as maybe on top of other things for the OR. And then all of a sudden they're sent up to the ward, maybe given some PO, a little bit of IV opioids. And now they're able to close the curtains and the patient's able to just go off. So certainly, and we do know accepting patients at shift change is a danger time, which is why we try to limit in that first hour. But I always, when I did work bedside, I always say, these are the patients that as you're leaving the unit, you're like peeking in like, hey, how are you? Because those are the most dangerous time. I think I've covered that. So this is just a graph to just, by no means am I saying don't put oxygen on your patients, but when you do, you have to be considering why. Why am I doing this? Because we do know when we are providing opioids and the patient is on oxygen, it can complicate and delay our identifying that we're in trouble. I always, whenever I walk into a room and I see a patient on oxygen after surgery, it's like, that's a real red flag. And, and the reason is, whenever I ask nurses, when do you kind of get a little, I don't even want to say excited, do you get a little where maybe I should put oxygen on, or maybe there's something going on? For most of us, it's around when your patient's SpO2 gets down to around 92%. That's when you're like, oh, okay, maybe they need some supplemental. But look what happens when your patient is on oxygen. I'm not sure if you can see my cursor, but way up here, by the time you identify that there's a problem, you think, oh, sorry, maybe you can see my cursor when I go over here, I apologize. So when you go over here, when you think by the time that SpO2 falls to 90, look at what's happening to their PCO2. So it's really like in the high 60s, almost 70. That's almost intubatable. When they're on room air, by the time you identify, you're going to identify them at kind of a high normal. Now, I always say, why are we putting oxygen on our patients? Certainly in the surgical world, it's could it be atelectasis from the ventilator, or is it that they've had opioids and that they're a little bit sedated and they are not appropriately or acceptably breathing? Either way, both of those need your intervention. So certainly there was a time when if you just started a PCA or you gave any opioids, you just routinely put on oxygen. Those days are gone. That is not a benign procedure that actually can cause harm. So just consider when you are putting on oxygen, still put it on. But these are patients that you are watching a whole lot more closely. All right, so we're going to talk a little bit about the PAUSE scale. So here, and I think for most of the hospitals, not only in the Lower Mainland, provincial wide, have adopted this Pessario opioid induced sedation scale. So hopefully you will get to know and love this scale. It is very well validated. For those of you going to critical care, we do use the RAS scale for those who are intubated, but once they become extubated, we do go over to the PAUSE scale. So this is the PAUSE scale. So 1, awake and acceptable. And I'm sorry, for those of you, if you are going to critical care, please don't use 2 scales at one time, only 1 scale at a time. And the reason is because, well, there's many reasons, but the one main one is that the numbers don't mean the same thing, and you can the patient could get lost in miscommunication with providers. So 1, awake and alert. 2, slightly drowsy, easily aroused. And 3, this is the part that I want you to pay attention, is that a PAUSE 3 is easily rousable. These are the patients that just can't stay awake for conversation. So those are the ones you go in and they're sleeping and they're like, Mr. Smith, and they wake up and they're looking at you and either they're super concentrating on you and their eyes are like peeled, or they're like, their eyes are just going back and they're going back off to sleep. This is where we want to stop. If we're waiting for, and I will tell you a couple of examples. So one patient I had, that was obviously a PAUSE 3, and they had a PCA, and it was a great experienced nurse who I went in and I said, oh, we're going to have to remove the PCA button. And they're like, so they come in with me and they're like, hey, Mr. Smith, what year is it? Where are you? And he was doing an orientation question, and I jokingly said with him after, that had as much to do with sedation as the cost of apples per kilogram. And the reason is that they should know where they are. If they don't, we have another problem, and that's part of a Glasgow coma assessment. This is sedation that we're looking for. Another patient that I had was when I went in and, oh my gosh, what was this one? Where, oh yes, and the fact that they were easily able to wake up, and their that was it, their rest rate was 24. They were like, no, they're totally fine. Their rest rate is 24. And then I was like, whoa, why is the rest rate 24? Because we only see the SpO2, right? That's the one number that we can check with that great monitor, but we don't know what the CO2 is doing. And for most of us, we are going to be able to compensate. So as our CO2 goes up, our rest rate is going to go up to try to blow that off. By the time our rest rate falls, your only decision is whether or not to give Narcan. It isn't whether or not to give opioids. And so I always say that if you're doing a really good sedation assessment, you should never have to give Narcan in your career for our opioids. Now, you will give Narcan in your career, but if we're doing a sedation assessment, you shouldn't have to. Now, I do want to pause and preface that if you have a patient being followed by our addictions medicine team, if you are going to be holding any opioids, they do wait for the rest rate to fall, but you don't want to apply that to the rest of your patients, okay? If you are going to be holding an opioid for our AMCT patients, please make sure to call that team. But it is a very different treatment and assessment with our patients. You do not want to wait until their rest rate falls. Now, I always tell patients, as soon as you're more awake, we're going to be able to provide you with a pain relief, because you can, like in my example with my brother, he did have 8 out of 10 pain. I always tell the story of this gentleman who had, he had 2 returns to the OR. He had a bowel surgery and an anastomotic leak, and he was waiting to go back. He had a PCA and he had ketamine and a rock hard abdomen. Like, you could just feel this poor man's pain from the door. And anytime you would wake him up, he would say, "It's too much. I can't take it anymore." And then he would, drift back sedated. And at that time, it's like, I completely understand that you have pain. They need to know you believe them, and you do believe them. But it's just not safe to give you any more opioids at this time. So what you're going to do is you're going to sit them up there so that you can assist with breathing. You are going to not provide them any more opioids. You can provide all other non-opioid analgesic, acetaminophen, NSAIDs, warm blanket, repositioning, anything else that is going to improve comfort. And then as soon as they're more awake, you can provide them with opioids, usually at a lower dose. This can cause quite a bit of moral distress for you, the family, because these patients can have a whole lot of pain. It's just not safe at that time. For the patients, luckily, they're not really going to remember that really, period, if you will. They aren't ever going to say, "Oh no, right after surgery, my pain was fine." No, absolutely not. They do have a whole lot of pain, but while you're waiting for them to be a little bit less sedated before you can provide any more opioids, it's that time that is a little bit, where it causes a lot of distress for us as providers, as well as for our families. So pause 3, easily rousable, but they cannot stay awake for conversation. And that is where we want to stop. And sometimes it's just an hour. You just wait an hour and it's safe to provide. The other thing, part of the pause scale, as you saw, is that sleep is a part of the scale. Now, we do know in these new guidelines came out in 2020 that very clearly said we shouldn't have a sedation scale that has S. But because, for numerous reasons, the pause scale is still at its fundamental core, still a really great sedation scale. But when you are writing S, really do consider, is this patient, if it's that first 24 hours, if it's at a time when you've changed opioids, or if it's changed the route of opioids, you really should wake up your patient to see if they are sedated. Okay. So that's it for that. So pause 3, this is where you want to wait. I always say it's a win. If we find patients at a pause 3, we are basing, we know that with the onset and the peak of whatever opioid we provided with them, we sit them up, we can monitor them a little bit more closely. But yes, I think this is where your sedation expertise comes in. I always joke that I used to have an actual dead canary on this, but yes, they used to take canaries into the coal mine, and the canaries are really quite sensitive to CO2. So if the canaries died, they knew that the coal miners needed to get out. So I always say your sedation assessment is your canary, and don't let your canary die. Okay, it's a lot more fun when people are in the room. Okay, so how do you assess sedation? I'm going to bet most of you are going to say you go in and you say their name. But what I want you to think about is that step right before that. Okay. What you're going to do is look at their breathing. You're going to count their breathing and you're going to see what kind of chest expansion you are getting. Okay. So always look at their breathing before you say their name to wake them up. Now I'm just going to, I have this, oh, I think we had trouble with the sound before. Let's try. She says, hopefully. Okay. Oh, I see her coming. No sound?
No sound. On the share screen side, on the left side, PJ, there is a
Yeah.
share sound. If you check, if you tick that share sound, then that might help.
Oh, sure. Where did you say that was?
On the share screen, on the left side of your share screen at the bottom, I think it's a share sound.
Okay. It's only 90 seconds. We'll see how he's going there. Sure. Okay. He's just breathing still. No, actually he stopped. There we go. Sorry. No. Okay. So what I just want you to see from this, who I've called Frank, is that you might be able to see him making a respiratory effort. Oh, I keep pausing him because I was trying to find the sound. Okay, so think about your patients with obstructive sleep apnea, and I do apologize for that. Is that think about even your why am I always saying your spouses or partners, somebody who snores, parents. What really happens is they have an open airway, they go off to sleep, and then they either have this complete apnea or this hypopnea, where that kind of partial kind of snoring. What happens in sleep apnea is that they have these mini micro arousals that kind of wake them up, that activates their pharyngeal muscles that cause that snorting or snarking. So this gentleman was making a respiratory effort. He was doing this. And if you went in with your flashlight to count, you might actually count some rest, but he's actually not breathing because you're kind of seeing the chest movement, but really listen to see that they are breathing. So in that video, this gentleman, he was doing a sleep study and he had 90 microarousals in an hour. That's more than one a minute. That's huge. First of all, that's going to be a very disruptive sleep. Just not going to feel like he's had a good sleep that night. And so what can you do for these patients? The problem with OSA and opioids is that the patients with OSA might not demonstrate sedation. The problem for them isn't when they're awake. The problem for them is when they're asleep. So it is reportable if you see that there's any breaks, if they've had a 10-second apnea and you have been giving them opioids, this is reportable to the primary physician. And we do have to make some amendments for sure. So what can you do? I always say, try to be as, convincing as you've ever been in your life, to encourage them to bring their own CPAP. The CPAP does act like a mechanical splint, so that it does keep these patients safe. So a lot of patients, my own father-in-law, I could not convince to bring his CPAP into a hospital. You say, no, they're going to lose it. It's really expensive. No. But really try to convince them. It's just so much safer when you are providing some opioids. A lot of patients will say, well, I've lost 50 pounds. I'm waiting for a new sleep study. It's like, I totally get that. But just while we're providing you with pain management and opioids, it's just a safer option. So yes, and if you do go in and you do find your patients are having periods of apnea, that really is reportable when you are providing opioids. And I would be absolutely waking these patients up. Okay. All right. Oh, there we go. So let's just talk. I've got 6 minutes here. I get too excited and I love it. So we do know that there are barriers to pain assessment. I always say that, patient barriers, at least 60% of people want a passive role in their pain management. And what that means is they don't want to tell you that they have pain. They're not going to put their light on and say, oh, I have pain. That they're really waiting for you to ask, and not only ask, but ask if they need something for pain. So sometimes, I'll see that the patients are reporting, an unacceptable pain level, and nothing has been given. And it's because really legitimately the patient hasn't asked for anything for pain. And oftentimes when you read in the literature, patients will report that, the nurse knows if I could have something, so I would have something if I could. So, I don't know, and I always jokingly say, nurses aren't given that crystal ball upon graduation. So really, certainly when they're followed by the acute pain service, I always say this is a partnership. And seemingly a lot of people are really apprehensive to ask for analgesia. And of course, patient barriers. Sometimes, oftentimes I have to be involved in doing opioid rotations, like for whatever reason. Sometimes we can decrease the amount of overall opioids required by doing an opioid rotation. And for some people, if I just say the word oxycodone, they're like, hey, whoa. I don't want to take that. The media recently has done a fairly good job. So this is a place to jump off on, to be curious and ask, what is the problem? What are you worried about? What are your specific concerns? Sometimes it is that, I've taken it before, I was terribly nauseated, I was throwing up, sometimes I can think it might be worth another try. That is an expected side effect with opioids. But if sometimes people are like, I know this is going to cause nausea, there's no point in even trying and just switching. So really just speaking the same language. By that, I mean, like when they ask what they, there certainly are some significant barriers to a pain assessment. So now when I talk about assessment, I really think, well, first of all, in the next 5 years, I really hope that we are going to get rid of these pain scales. I had a patient this morning who is really quite comfortable. I asked her what her pain was. She says, oh, it's a 6 out of 10. And I'm like, oh, is that okay for you? And she's like, yeah, it's totally fine. She knew how the pain scale worked, but the problem is the pain severity, and it's 6 out of 10. You chart 6 out of 10, but 6 out of 10 for this patient is absolutely acceptable. So you just have to put what the patient's goal is and having that discussion, because I always use the example of my mother-in-law who has acute on chronic pain. She's had osteoarthritis since she's been about 18 years old. And I remember doing practicing a presentation when she was visiting. And again, from all outward looks, she looked okay. She said her pain on her best day is about 7 out of 10. That's what she has to deal with, and how she's learned to function and how she's learned to live on a daily basis. So now if she came into hospital, do you think we're going to ever get her down to a 3 out of 10 because some arbitrary? Pain severity tools are really good to assess the effect of your intervention. Their pain was 10, I provided a warm blanket, it went down to an 8. You can see that there has been some improvement, but other than that, this is not how you choose a treatment plan for your patients based on the severity scale alone. And I just love that. I don't know why, I've got a terrible sense of humor, but this was on, I think, BuzzFeed. And it said, Grayson just asked if 10 is a big number. And what do I tell him? Because $10 isn't a lot of dollars, but 10 murders is a lot of murder. And the take home from this joke is that context is important. When we are assessing pain, it is so much more than just a one-dimensional number. So do use it as part of a fulsome pain assessment, but don't be choosing a plan based on the number alone. Hopefully in the future, and I'm hoping 2023 will bring us the addition of the functional pain scale. I wish we sooner chose a different pain scale, but this is very well validated. It just seems to go from mild limitation to significant. All right, so that's it. Just don't treat a number. All right, that's the accreditation standards, and I think we can make it. It's just at one during every shift for inpatients, after interventions for care, and at transitions. And of course, ask more frequently. So that's it. Is that really? I didn't even do a final, like, yes. All right, there we are. That is it for me. I guess we don't have time really for questions. Do forward me any questions that you have. And welcome to Providence Healthcare.
Thank you very much, PJ.
Thank you.
Okay. Thank you, everybody. We're walking into the next topic, which is the wonderful world of wound, ostomy, and continence. And here with me is Joanne. She's one of our wound care nurses, and she's going to tell you more about the wound care.
Hi, everybody. So as she was saying, my name is Joanne. I'm a wound ostomy nurse here at St. Paul's Hospital. Goodness, sorry, I just need to figure out how to use this. Okay, so our title is NSWOC. So what is an NSWOC? It stands for Nurse Specialized in Wound, Ostomy, and Continence. Here in PHC, our team consists of 5 NSWOCs. So there's 4 here at St. Paul's Hospital, and there's 1 that covers Mount St. Joseph and the long-term care sites at Providence. So we provide clinical care, education, research, and support to all of the PHC sites, and our hours are Monday to Friday, 8 to 4, and we're not here on stats. So this is our team contact information. This should be in most or all of the nursing stations around the hospital. And so it has our office number, office hours, as well as our cell phone numbers in case you need to get a hold of any of us specifically. So I'm going to be talking about wound care now. So in terms of nurses' scope of practice, all nurses can actually make nursing diagnosis and direct management of wounds above the dermis. So NPs, RNs, and RPNs can make nursing diagnosis and direct management of wounds below the dermis. And LPNs can perform wound care below the dermis when a wound care plan has been determined. So what does this mean for nurses? Basically, all nurses can and should assess all wounds and manage the wounds within their scope of practice. So to do this, I'm going to talk more about using appropriate resources for some people who maybe aren't quite as knowledgeable about wounds right now, as well as to help you create and reevaluate care plans. So it's when wounds are out of the scope of practice or it's deteriorating despite the current care plans that you would want to collaborate with either our team, provider, or allied health. I'm just going to stop for 1 second.
Code blue, Providence 7 Delta. Code blue, Providence 7
Oh,
Delta. Code blue, Providence 7 Delta.
sorry about that. Basically, we ask that, you try and do what you can within your scope of practice, and then continue caring for the wound or ostomy until one of us is able to assist if it's something that is out of your scope or is deteriorating. So these are just some examples of wounds that are within nurse's scope of practice. So there's moisture-associated dermatitis. So when you have, in the summer, it's really common when it's really hot, some people get really sweaty, and under folds, you might get, a rash or something like that. And then there's also incontinence-associated dermatitis, as you can see from this photo, skin tears, pressure injuries, stable chronic wounds, or healing complex wounds are also within the scope of practice, and many others. So what resources are available? So I'm going to talk a little bit more about these 4 different resources. We have the Learning Hub, Shop, Click.ca, and the Wound Ostomy Continence homepage on PHC Connect. So in terms of education, there's wound care courses available through Learning Hub. So we have a wound management curriculum, there's a provincial curriculum, intro to wound care course, as well as a negative pressure wound therapy for those who are, pretty good with wounds already and want to do something a little bit more advanced and more in development. So this Learning Hub would be the place to take wound care courses. There's also Shop. So Shop would be the place that you would go to for guidelines, procedure documents. So like if you need to know about a policy about something you've never done before, Shop is your go-to site for that. There's also a provincial website. It's called Click.ca. They recently revamped it, and there's lots of really great information. We frequently use the site ourselves. So basically, this is an ostomy care community of practice website, and it houses all the documents that have been standardized across the province. And so these documents get created by provincial committees that include OTs, PTs, like allied professions, all of that good stuff. So yeah, another really great resource for just anything wound related. It also includes product information sheets. And so this is great for somebody who, let's say, isn't that familiar with different types of wound care products. You can go there and just look up different products to give you information about indications, precautions, contraindications, as well as instructions on how to use the actual products. So you can either find it through click.ca, but you can also find it through Shop and the NSWAC homepage, which is what I'm going to be talking about next. So through PHC Connect, you can actually find our NSWAC homepage. If you go under nursing, and under nursing, you'll find woundostomy continence. And this will give you a whole bunch of different documents and resources for anything, absolutely anything woundostomy and continence related. So one really great resource that I think everybody should know about is a topical treatment grid. So this can be found in our NSWAC homepage as well as Shop. But basically, it's a great resource to have if, let's say, it's Friday night and you're alone, don't know a ton about wounds. We're not going to be around because it's a long weekend until, let's say, Tuesday. So this is a great resource to see what kind of products you could potentially use on a wound if you're not really that certain. So you would just look at the photo and then you would look at the different treatment options, and you can use that as dressings until one of us is able to see the patient when we're back. So if you're ever in doubt, let's say there's a wound that doesn't really look like anything in that photo, but you really think that we need to see it, then a really simple thing that you can do is just place a non-adherent contact layer on the wound. So examples would be Adaptic, Bactigras, Gelinet, Mepitil, just so it doesn't stick. And then a breathable absorbent cover, so something that doesn't hold moisture in. So Mesorb, Abdopad, Exudry, Super Soaker, and then just change it daily. So if you use this type of care plan, it's pretty harmless. It should be fine until we get to see this patient. We don't recommend you leaving a dressing on because we're not available, because sometimes it can be 4 or 5 days until we see somebody. So definitely at the very least, just change the dressings. This is a pretty, it can kind of work with any sort of wound. And so it's pretty safe if you just apply this principle, or going back to the wound care grid. Okay, so when would you consult our team for wounds? So as I was mentioning, if the wound is out of nursing scope of practice, if the current care plan is not working, and if the wound is deteriorating, or you're just unable to find resources to help create a care plan. These are just some photos that I wanted to share that would be managed by our team. And I consider relatively complex. So in terms of our role with wound care, we create wound care plans for complex wounds. We do the assessment and management of them. We can also access community records and facilitate interdisciplinary team care. So if you're going to do a consult with us, we ask that you be present for our consults, assist with dressing removal, cleansing, and assessment. And the bedside nurse will apply a new dressing after the NSWAC assessment is complete. So if you're on a break or you can't be present, please just either reschedule or let someone else know so someone is available to be there with us. That would be greatly appreciated. Now I'm just going to move on to ostomy care. So in terms of established ostomies and the nurse's role, for the most part, if a patient's independent, they have their own supplies, we don't actually need to be involved. So just because a patient has an ostomy doesn't mean that our team always needs to be involved. Sometimes all they need is their supplies. So it might be a matter of the patient's family or friends bringing it for them. We can also use our own hospital supplies, or sometimes suppliers will deliver directly to the hospital. If it's a matter of, a patient needing help with pouch changes, the nurse can assist and complete with that as necessary. A reason why you might need to consult us is, let's say there's peristomal skin issues, or the pouch is leaking because, there's some sort of pouch issue, or if an irrigation is required. That's definitely something we get involved in as well. But please don't refer to us just because they have an ostomy and need regular pouch changes, because that's not something we need to get involved in. In terms of new ostomies, If we aren't already involved, definitely send us an ostomy consult, because we absolutely need to get involved if it's a new ostomy. If it's, again, a weekend or a Friday night and we're not around, we would still ask that you do an assessment every shift, and you would just document that on iView. If it's, the ostomy appliance is intact or whatnot. Generally, you want to change the appliance post-op day 3 or the first sign of a leak. You never want to leave it on if there's a leak. You never want to just reinforce an ostomy appliance if there's a leak, because it can actually be very harsh and damaging to the skin if you just let that stool skin sit there. So we definitely recommend changing it right away at any sign of a leak. And if possible, we do recommend just initiating patient teaching. So teaching them stuff like burping the bag or emptying the appliance, because that kind of stuff can just help facilitate discharge, because we want to make sure that they feel comfortable doing that before they go home. For those who work on 10AB, your surgical orientation will provide you with more information about your role with patients with new ostomies. So in terms of our role with new ostomies, usually we see them before they even have their surgery. So typically we'll do the pre-op teaching and counseling. We also do a stoma marking, trying to find the best spot for a stoma. Post-op teaching, we follow up with them to continue teaching, answering whatever questions they might have. We also arrange for follow-up after they get discharged, as well as where they're going to buy their supplies. So we also deal with complex ostomy general complex ostomy management, both for new and for old stomas. Now I'm going to talk about continence care. So there's a role here in the hospital as well for called a nurse continence advisor. So it's quite different from us. So if there's ever an issue with fecal or urinary incontinence issues, you'd actually want to be contacting the NCA, so nurse continence advisor. If it's skin related issues regarding incontinence, so let's say moisture associated or incontinence associated dermatitis, then that's more would be something we would deal with. So yeah, if it's skin issues, contact us. But if it's actual like fecal urinary incontinence issues, you'd want to contact the NCA. In terms of suprapubic catheter changes, if there's a patient that just needs a routine change, we're not the team that goes around and just changes everybody's suprapubic catheters. It's actually like a shared responsibility and education that we're trying to promote and show people how to do, because nurses is something that nurses should be able to do. So if you have a patient that needs to have a suprapubic catheter change, just check to see if there's anyone else who already knows how to do it. And if you can't find anybody, then we will actually come and teach you how to do it. And help you obtain competency. Okay, so now I'm going to talk about how to enter an NSWOC consult. So basically you go under orders, and under orders, you're going to put in wound care clinician consult. So not just wound care or not wound care clinician following, you need to put it down as a wound care clinician consult so that it pops up into our list. Sometimes what people do is they'll put it under wound care or something else, and it won't show up on our list. So really important to make sure you're putting in the appropriate consult. And the same would be applicable if you're going to do an ostomy one. So just make sure it's ostomy care clinician consult. So when you're doing this, please write a reason for the consult and add comments, whatever kind of description you want to give us, just because it helps us with prioritizing our referrals. At any given point, you might have tons and tons of referrals. And so it helps a lot if you give us a little bit of detail to determine like who needs to be seen first or whatnot. So sometimes there's already patients that we're seeing that, and if that's the case, you don't need to put in another consult. If you want to check if we are already following, you would just go under consults, and then it'll say wound care clinician following or ostomy clinician following. If that's the case and we're already following and you want to tell us something about, an update, or if you're concerned something's getting worse, just give us a call directly. And then we will see the patient as needed. But please don't put in another Cerner consult, because we don't really want to use it as a communication tool. It's not meant to be a communication tool. So just give us a call if we're already following a patient. In terms of Cerner documentation, there's a manual on PHC Connect. So as I was mentioning, our NSWOC page on PHC Connect has a section on Cerner resources. So if you ever want to get any information about Cerner documentation, this is where the resource is if you need to get more info. in terms of documenting ostomy and wound care, it all goes under iView. So if you go under iView, you've got incision wound skin pin site care, or you've got GI ostomy. So you would just click on whichever you're documenting on, and then you would just tick on the appropriate boxes as shown here. Same thing with wounds. And yeah, you just tick whatever is appropriate. So all the wounds require documentation on every ship. So not just when you're changing it. It might be just a matter of saying, okay, the dressing is dry and intact. So now I'm going to talk a little bit more about some important points I think people should know about wound and skincare. So guiding principles for skin integrity is moisture balance. So if you have too much moisture, 5 times more likely to ulcerate. If there's too little moisture, then you're actually 2.5 times more likely to ulcerate than healthy skin. So because of that, we have a bunch of wound care products in the hospital, and I'm going to go over a little bit more about this so you can learn about it. But if you forget everything that I've told you, all this stuff can also be found either on click.ca or our Woundostomy homepage. So some key points, key skincare products. So there's just a nourishing moisturizer. It's like the purple bottle. So this is good for just general skin health, preventing skin tears. And if the skin's dry, it just helps to keep it moisturized. So when you have somebody who's incontinent though, so if you have mild to moderate incontinence and let's say the skin's intact, we actually recommend the HydraGuard. So it's like a moisturizer, but it's blue instead of the purple. So this one just kind of helps prevent that incontinence-associated dermatitis. So we recommend just putting a really thin layer after every episode on anybody who's incontinent but has intact skin. So when you have somebody who has severe incontinence-associated dermatitis, that's when things are like weepy and, open, and it starts to, get kind of painful for the patient. Then you want an actual really thick layer to prevent that skin from breaking down. You would use EPC. And you would apply it like icing on a cake, basically. So you want to put it on quite liberally. Also want to mention no rinse skin cleanser. So like for bathing in general, where the cleanser this cleanser doesn't get rinsed from the skin, also recommend using that. And so for EPC, what I was just speaking about, this is just a visual on how you would actually apply it. So yeah, you want to put it on quite liberally. And then when a person, if they need to be changed, their pad needs to be changed, you only want to remove the soiled portion of the EPC as needed. But you don't really want to be rubbing the whole thing off every single day or every single, time they need their pads changed, just because there's these granules on it that can be quite hard on the skin. And so it ends up just not being that great for their skin if you're constantly removing it. So only remove it, PRN, the soiled portion, and the whole thing you can actually remove every 3 days just to assess the base. And then you would use that no rinse skin cleanser I was talking about previously. And so how you would use it is just spray it, let it sit on the skin for about 30 to 60 seconds. It helps to just break it down a little bit better to come off. And then just wipe it off with white balls. Now I'm going to talk about pressure injury. So what are pressure injuries? Basically, they're unrelieved pressure on the skin and disrupting blood flow and the capillary networks. It impedes blood flow and deprives the tissue of oxygen and nutrients. And because of that, it can lead to either just a mild reddening of the skin to severe damage that can extend down to muscle and bone. So causes, we've got pressure, friction or shear, and also moisture and dryness. So what areas of the body are at risk for pressure injury? So this is the whole list of pressure injury sites. And basically they're mostly bony prominences that would put them at a higher risk. So shearing. Shearing occurs when the skin stays in one place while the bone moves downward. So what this does is it compresses the blood vessels, stretches and damages the blood vessels. And so it can result in undermining once it gets kind of to, like a more extreme state. Then there's friction, which occurs when the skin is rubbed against another surface. And so things that you can do to prevent this is keeping the head below 30 degrees, raising the knee before the head, so you're preventing that sliding, using sliding sheets or sling, avoid layering sheets and making sure you're using the correct linen. And same thing with friction. You can do the same thing with all of the above, but you can also add a Tegaderm or transparent film just to help prevent that friction. What else can you do? So seating and bed positioning, really important. Adequate repositioning. So usually Q2 hours or more. Even small shifts in weight can make a really big difference. Also keeping in mind that even if somebody is on a pressure redistribution surface, it doesn't mean you could just leave them there 24/7. Like you still do need to keep turning them. And yeah, so the pressure redistribution surfaces as needed. Offloading the heels, either using the boots or the heels up, and rule of 30, so turning 30 degrees side to side, keeping the head of bed under 30 when able. So for pressure injury resources, we have a whole whackload on our website. So if you go under the wound on our NSWAC homepage, there's a whole section on pressure injury prevention. Because of accreditation, we have been doing tons of we've done in-services, we've also done podcasts, and there's one pagers and stuff. There's a whole bunch of stuff on there. So if you're looking to learn more about it, highly recommend checking out the site. So information that you can find in there include, the different types of support surfaces. We have algorithms to determine, okay, based on person's Braden score and all this stuff, like what would be the best support surface and how and when to use pumps. So currently, Mount St. Joseph and St. Paul's are using Atmosair 9000A as a standard mattress for most units. So basically, it's a pressure relieving mattress designed to treat, prevent pressure injury, and you can add a pump to increase the pressure redistribution. So sometimes, it's not a one size fits all. There's some people that are going to need something with more pressure redistribution, and if that's the case, you're just going to, as mentioned, go onto the pressure injury prevention guidelines section, and then just look for the algorithm to determine what would be the best mattress for them. And so CNLs must approve the specialty mattress before actually being able to order it. Now I'm going to talk a little bit about a few random safety and treatment considerations when it comes to wounds. What kind of wounds are these? So we call these arterial insufficiency wounds. So the reason why they're black is because there's just not enough blood flow to get to that area. And so because if there's not enough blood flow, it's just not going to heal. So when we have wounds that we know are not going to heal, the goal is just to maintain them and decrease the chance of infection by keeping them dry. So why we want to keep them dry is because with wounds with minimal perfusion, bacteria actually love the moisture, and therefore they're going to want to be drawn to it if there's a lot of moisture. So if you have a lot of bacteria that are, congregating there, an infection could potentially occur. And if that were to happen, the antibiotics might not be able to get to the site of infection. Then there's that risk for systemic infection and a possible amputation. So stuff you really, really don't want to, have to deal with your patient. So again, that's why the goal is just to keep it clean and dry. And by doing that, a few do's and don'ts. Don't cleanse with normal saline or tap water. Don't soak it in a tub or bath. You want to protect the wound when there's a patient's showering, and painting the eschar with povidone iodine, or if that's not available or if they can't tolerate it, chlorhexidine is also another good alternative. You can moisturize the surrounding area that you're not painting, but you definitely don't want to add any moisture. And so one way to add moisture is using moisture retentive dressings. So imagine something like a Tegaderm. You don't want to wrap it around a Tegaderm because that's just going to make it all sweaty and moist. And that's just an example of what you don't want to put on if you have a wound with arterial insufficiency. Another thing I want to talk about is CNS samples. So when somebody orders a CNS sample, one of the things that I always recommend is not to swab necrotic tissue or existing drainage. The appropriate way to do it is actually to clean the wound really well with saline first. And then afterwards, you want to swab 1 square centimeter for about 5 to 10 seconds until the tip is saturated. So you're pressing into the wound bed to express wound from within the wound bed, not just swabbing whatever is just existing and sitting there. Okay, so that concludes my presentation. Are there any questions right now? Okay.
What color caps? So it's in slide. It's in the Chrome. Just pull up the Chrome, just hit.
Oh, here.
Yep.
What color caps? I think they're blue. Honestly, okay, yeah, so the question, what color caps do the CNS swabs have? And Carrie has answered, it is blue. Anything else? That's it. Okay, thank you, everybody.
Thank you. Hi, everyone. Let's get a 5-minute stretch break while we prepare for the next presentation. Thank you.
Perfect. Thank you, Carrie Ann. Welcome, everyone. So again, my name is Leanna Peruzza. I'm the nurse clinician for transfusion medicine. And today I'm going to go over safe transfusion, what you need to know. Before we get started, I'll just ask the group here what their level of experience is with transfusing blood products. So, oh, that's not the right one. Sorry, guys. Just one second. Okay, there we go. Oh, not this one. Sorry about that. Okay, there we go. So what level of experience do you have transfusing blood products? So I'll get you guys to respond to that, and then we'll move on with my presentation. And then how many participants do we have? Okay. Okay. Okay, great. So this just kind of gives me an idea of where everyone's sitting at right now. So it looks like a majority of people today have had no experience with blood products or transfusing any blood products. So we'll be going over that today. So I'm just going to start my presentation here. Okay. So the learning objectives today are to review the training that's required in order to safely transfuse blood products. I'm also going to go over the resources. I'll also review group and screen collection, which is really important when it comes to administering blood products. I'll also go over administration and transfusion reactions. And so like the main goal today is just to kind of review with you our standard practices when it comes to transfusing blood products. I'll show you some of the documents that we have in place. And then also I'll provide you with an opportunity to ask any questions related to transfusion medicine at the end. Okay, so what training is involved in order to safely transfuse blood products? So the first one is this Go PowerPoint for safe transfusion. The other training that you'll receive is through the Learning Hub. And the course is called the Nursing Competency Blood and Blood Product Administration. Each year it's required for nurses to complete this. And it's in order to meet Health Canada accreditation requirements. Once you've completed it, you'll get a reminder the following year that you need to complete it again. And if you are on a unit that's administering blood products, it's required that you complete this yearly. You'll also get additional training to the unit that you're on through your educators, and they'll go over the workflows and unit-specific orientation as well. So some of the resources that you can use and help guide you when it comes to administering blood products are our SHOP documents, which is also referred to as the Shared Health Organization Portal. This site here is going to be your primary site when it comes to reviewing our protocols for anything here at PHC. So here you can find the group and screen collection. So it provides you information and step-by-step guidelines as to how to collect a group and screen. You can also find the blood and blood product administration protocol. So this is something that you're probably going to be referring to quite often when it comes to administering blood products. And this contains need-to-know information and a step-by-step guide to product checks, monitoring, and documentation. You'll also find the IVIG protocol, and most importantly, blood and blood products, transfusion reaction identification and management. So this provides you guidance into or how to manage a patient if you suspect a transfusion reaction. Additional resources include the quick reference guide, which is found in the blood administration SHOP document, and it's actually considered an appendix. It's at the end of the document. And the information that you can find here is, it provides you with quick information about the blood components or products, when a group and screen is required, what IV solution is compatible with the products that you're using and to prime the lines, and what type of tubing you might need as well when it comes to administering all these blood products. So these can either be found on the education board and resource binders or near a patient's chart or the chartlet. So here is an example of what the quick reference guide looks like in the SHOP document. So if you look here on the left-hand side, we have the product, the indication, the turnaround time just refers to how long it takes for transfusion medicine to get this product ready for the ward, the volume of that product, what compatible solutions that you can use to prime the line, the type of tubing, the rate that you're going to start the infusion at, and what the max rate can be, if a group and screen is required, and any additional information as well. So this is going to be your resource guide when it comes to administering your blood products. Additional resources include the Cerner transfusion history page, which can be found on the handoff tool. And on the next slide, I'll show you what that looks like. So this provides you information in regards to the group and screen status. So it tells you the expiry date and time. It also tells you about the blood product availability. So it tells you when a product has been allocated. So that means it has been tagged down in transfusion medicine and it's ready for pickup. It also states when it's been issued. That means it's left transfusion medicine. And then presumed transfused just refers to that the products haven't been returned back to transfusion medicine within 72 hours. So we assume that those products have been transfused to the patient. And we can also find the transfusion reaction history. So if your patient has had a transfusion reaction, you will find information there in regards to some guidance as to what you need to do for that patient if you're going to give any other blood products. So here is a screenshot of what the Cerner banner bar looks like for transfusion history. So you have your group and screen status at the top here, your blood product availability, so if it's allocated, issued, and then presumed transfused. And then down at the bottom, it states the transfusion reaction history. So if a patient has a transfusion reaction, our heme paths will enter a comment, which will be displayed in there, what type of reaction that they've had and any additional like pre-medication they might need for their future transfusions. Also, additional resources include the clinical procedure for all suspected blood component and product reactions. And this is found on the back of the transfusion record. So it's a paper that comes attached to the blood component or product. And on the front of it is where you sign when you're administering the product or transfusing the product. So this quick reference guide tells you what to do, what order, and what to return to transfusion medicine. It's at your hands, it's quick and easy to read, and it's very helpful instead of having to go back into the protocol. So here's an example of what the quick reference guide looks like for a suspected transfusion reaction. So this is on the back of the transfusion record. So you have your steps here and the types of, at the bottom here, it also indicates what type of diagnostic tests that need to be done or any blood work that needs to be done depending on the type of reaction as well. So last but not least, our resources include people. So this includes a transfusion medicine bench staff. So whenever you call down to transfusion medicine or blood bank, those two terms are interchangeable. You'll talk to one of our bench staff. So they are experts in our products. They are not experts in nursing procedures. So if you call down asking, how quickly do I need to infuse this product? They won't be able to provide you any guidance with that. That will be your educators, myself, and any of your senior nurses on the ward that you're working on as well. We also have hematopathologists. They're available 24/7 and they're able to help guide you when it comes to transfusion reactions. They also follow up on transfusion reactions as well. You have your unit educators, so they're experts on nursing procedures and policies related to transfusion medicine, and then myself, the clinician. So if you have any questions in regards to any blood products, how you need to transfuse this, I'm available. I do work part-time, so I'm available in office every Tuesday, Wednesday, Thursday. Okay, so now that we've gone over the resources and the training that's required to administer blood products, we're going to talk about our group and screen collection. So when it comes to administering blood products, we need to make sure that we have the appropriate blood type in order to give to that patient. So if we were to give the incorrect blood type, that could be quite deadly for the patient. So it's really important that when we collect our group and screen, that we're doing our positive patient identification. This is the first step that we need to complete in order to collect our group and screen. And in order for any blood products to be allocated or issued to the ward, we need a valid group and screen. And group and screens are valid for 72 hours if it's an inpatient. So what do you need to do when it comes to positive patient identification or collecting your group and screen? We want to make sure that we bring all our supplies into the room, have the patient confirm their identity by asking them to say and spell their name and give their date of birth. And you want to compare this information to the banner bar or the paper requisition. If the patient cannot confirm their own identity, so if they're unconscious, which we usually see in the critical care settings, we're going to have an alternate person there to identify the patient and use their ID band as well. So when it comes to collecting our group and screen, we always want to make sure that we're using that positive patient identification, so using Sunquest Collect. So the steps in order to correctly collect our group and screen include, so the first step here is that we're going to log into our Power Chart or FirstNet, select the appropriate patient, review any orders or single patient tasks. So this will be under the nurse to collect. If it's a unit where nurses, it's within their scope of practice to collect group and screen or blood work, or if the patient has an IV access that nurses are able to access. So in areas where the patient doesn't have a central line or any other big bore IVs, then it will be the lab that comes up and collects the group and screen. So once we've reviewed our orders, we want to make sure that we pair our wireless printer and scan the patient's ID band. So once we've scanned the patient's ID band, the information will come up on the next screen here, which I've provided. So it shows us what type of blood work needs to be collected. So it's our group and screen. So what we're going to do here is select any of these tubes here. Both of them will be highlighted, even if you select one of them. And so once we've checked both of these, there's going to be a red exclamation mark that appears, and we're going to click on that. And what happens is our screening questions will appear. So our screening questions that appear are the ones on the right-hand side of the screen here. So what we're asking is for the collector to follow these steps. Did you follow site policy for positive patient identification? You're always going to select yes. So you're going to check on that box there. Then the second question is, who was the patient or who provided patient identification? So is it the patient that self-identified, or is it an alternate person? So an alternate person can be a family member, a guardian, or a second healthcare provider. It's not the person who's actually doing the collection. It needs to be another person, healthcare worker. So once you've identified this, you're going to select the appropriate box. And if it's B, alternate, you're going to type in here who the alternate person is. And then you're going to select the apply button, and then your labels will print out for you to place on your samples. Okay. So just a few friendly reminders here is that best practice is to use Sunquest Collect to collect and label the samples at the bedside. Always double check the labels before you leave this bedside, and make sure the labels are legible and not cut off, and make sure that it contains all the patient's information. So their demographics, their MRN, their first and last name, and their date of birth. If any of this information is missing, transfusion medicine won't process these samples. So now that I've reviewed how to collect a group and screen using Sunquest Collect, I will review how to collect, group, and screen in areas that don't use Sunquest Collect, so don't have the printer or the scanner, or when it's downtime procedure, so none of the printers are working. So what will happen here is that any order that gets put into the computer for a group and screen, a paper requisition will print out no matter what. If you are using Sunquest Collect to identify your patient, you're going to discard this requisition. In areas that don't use Sunquest Collect, you're going to grab the sheet here and bring it to the bedside when it comes to identifying your patient. And those screening questions that were on the previous screen are similar to what's on the requisition here. So you are going to identify the patient. If they're awake, you're going to get them to identify themselves, or if they're unconscious, you're going to get an alternate. You're going to select the appropriate box and then fill out the name of the alternate person. Down below, you're going to fill out the date and the time that the sample was collected and who was collected by. So remember that the person identifying the patient can't be the same person who collects it. So once you've filled out that information, you want to make sure that you place your downtime labels on your samples there and send down the paper requisition with the samples. If the samples are sent down with no requisition, if you're using downtime labels, then transfusion medicine won't process these samples. So again, friendly reminder, always double check the label before you leave the bedside, make sure it's legible, and then make sure that the label matches the requisition as well. So we're just going to move on to administration now. So some things to think about in order to administer any blood or blood products to your patient. So first off, we need to make sure that we have an order. So this can be found in Cerner. We also need to make sure that we have valid consent. So this is completed by the most responsible provider, not by nursing. Nurses are responsible when it comes to administering these products, checking in the chartlet to make sure that it's filled out correctly. And if it isn't, then you need to address this to the physician, because you can't give any blood products if a consent form is not filled out correctly. So for inpatients, consent is valid for a whole year, or sorry, for the whole admission. And then for outpatients, consent is valid for 1 year. And then we also want to make sure that we have a valid or in-date group and screen. So blood products won't be issued unless there's an in-date group and screen. And that can be found on the transfusion history page. So now that we know as a nurse what we need, our order, our consent, and an in-date or valid group and screen, we need to think about what our patient needs at this point in order to administer these products. So some of the things that we need to have ready is that we need to make sure that our patient has proper IV access. So you can refer to the quick reference guide for the most acceptable forms and sizes of access. We also want to make sure that we have a baseline set of vitals and assessment done prior to administering any of these products. This can be done 30 minutes prior to the product coming up. And this is just to make sure that we have a baseline assessment before we give these products, because when we give these products, we're also looking for any type of transfusion reaction. So if their vitals are different from their baseline. We also want to make sure that we educate the patient as to why they're getting these blood products and know what types of signs and symptoms to look for a transfusion reaction. We also want to make sure that we have our equipment at the bedside. So this includes a pump and our emergency line in case we need to stop our transfusion. So here is a screenshot of what our transfusion order would look like in Cerner. So on the left-hand side here is our TM red blood cell transfusion module. And then on the right-hand side here is what the actual order would look like. It would state how many units, the time frame, and any other special instructions as well are in here as well. So now that we have our order and we have our equipment, how do we get our blood product or component? So in order to pick up any blood products from blood bank, we need a pickup sheet. And this is required in transfusion medicine for all components or products to be released. So this can be printed out from Cerner, or you can use a downtime form. It can either be brought down in person, faxed, tubed as well. So on the left-hand side here is what the Cerner requisition looks like that gets printed out when your blood products are ready to be picked up. And then that's the left-hand side. And then on the right-hand side here is the downtime rec. So if you can't print out one of the Cerner generated recs, you can fill out the sheet here. So you just need to make sure you put a patient's label on the top, fill out the date, the area that needs the blood products, who's collecting, the type of units or the product, how many units you're picking up as well. So now that we've picked up our product, we can start to administer this to our patient. So some of the things that we need to do is we need to complete our safety checks. So this entails a 2-person double check. Each person takes a turn reading and then listening. The goal is to ensure the right person gets the right product. If you get distracted or someone comes in and starts talking to you, you need to make sure that you start all over again, just so that information is correct. You're going to use a Cerner banner bar, the transfusion record, product label, and ID band when it comes to confirming all this information. And the last check is always done at the bedside, and that involves the patient if possible. So if they are awake, then they will be able to reiterate their name and date of birth as well. If they're unconscious, then you're going to have to get another nurse to come to the bedside to confirm that as well. So a friendly reminder here is that when it comes to your checks, we never want to write on the product label, so on the bag or the bottle, as the ink might leach into the bag. It's okay to write check marks on the piece of paper, the transfusion record, but not actually on the products. And if a product is sent up to the ward and you're busy with other patients and you feel that you cannot transfuse this or start this product transfusing within 30 minutes, you need to return it back to transfusion medicine. So here's just pictures depicting what you can and can't do. So it's okay on the left-hand side here to write on the transfusion record, but it's not okay to write on the product labels. So when it comes to administering these products, we want to make sure that we're monitoring our patients. So we're going to stay within sight of them for the first 5 minutes. We're going to complete our vitals 30 minutes before, at the 15-minute mark, hourly and post. And during this time, we're going to look for any new signs and symptoms of maybe a transfusion reaction. Okay. So now that we've gone over what entails what the steps are when it comes to transfusing any products, I'm just going to go over transfusion reactions. So if you suspect a transfusion reaction, and if you are unsure of what a transfusion reaction looks like, on the back of the transfusion record and in our protocol or shop document, kind of gives you guidelines as to what types of reactions you can expect to see. So that is also your reference guide as well. But if you suspect that your patient is having a transfusion reaction, the first thing that you're going to do is stop that transfusion. And you're going to refer to the quick reference guide, which is on the back of the transfusion record. And so that's going to provide you the guidelines or step-by-step what you need to do if you suspect a transfusion reaction. So the next step would be to make sure that we have our emergency line available. And this is to run TKVO. It's an emergency line just to make sure that the IV is patent. We don't want to be bolusing our patient any additional fluids at this point. We want to also assess our patient and determine what is different from our baseline assessment. We're also going to notify the most responsible physician and transfusion medicine as well, if you suspect a transfusion reaction. And then the next step is you're going to be following the physician's directions. So one of the things that we need to make sure is that if they suspect a transfusion reaction, the physicians should be entering into Cerner the power plan for a transfusion reaction. And there we'll show you, on the next slide, I'll show you what it looks like. But it guides physicians as to what diagnostic tests need to be collected at that point. Okay. The next step would be to complete the transfusion reaction report form. So this can be printed on FormFast. So nurses are expected to fill this out and send it back down to transfusion medicine. And then, if possible, send any samples or blood components and products with the tubing to transfusion medicine as well. So here is what the power plan looks like, or module in Cerner. So on the left-hand side here, we have adult ped TM transfusion reaction module. So when a physician enters that, this is what appears on the right-hand side. So physicians can select either transfusion reaction notification. So no further workup needs to be done, but it's just letting transfusion medicine know that there was a suspected transfusion reaction. And then down below, we have the transfusion reaction investigation. So if they decide that further investigation needs to be done, so any diagnostics or blood work, they will select that there and click on the appropriate blood work that needs to be collected as well. So here's just a screenshot of what the transfusion reaction report form looks like. So when you go into Cerner, you're going to click on FormFast if you're under your patient's chart as well. So click on FormFast and then type in transfusion reaction report form. And this is a sheet that will appear. You need to print this out and fill out the front of the sheet and send it back to transfusion medicine. Okay, that concludes my presentation for transfusion medicine. I just have some questions for you guys, just to see if you're paying attention there. There we go. Oh, no, sorry.
It's just a go.
Thank you. There we go. So where is the best place to find information 24/7 on how to safely administer blood products? Great. It looks like everyone was paying attention during that presentation. So the correct answer is a quick reference guide and the blood product administration document, which is found in SHOP. This is going to be very helpful for you. So once you start working on the unit, I would probably print this out and use it as your reference guide as well. So we'll just move on to the last question here. So your patient is 15 minutes into an RBC transfusion and they report feeling itchy. You notice a rash starting to form on their chest and arms. What should you do first? Okay, great. It looks like everyone answered this one correctly. The first step is to always stop the transfusion and then contact the doctor to let them know as well. Perfect. Okay, perfect. Great question here. So what is the difference between allocated and issued? So allocated just means that blood bank has taken out of the fridge the blood product that your patient needs and tagged it. Issued refers to that someone from the ward has come down and actually picked up the product and it's no longer in transfusion medicine. So the next question here is, why is the group and screen only valid for 72 hours? This is an excellent question here. The reason as to why a group and screen is only valid for 72 hours is that if we are administering lots of blood products to our patient, they are susceptible to develop different antibodies. So we want to make sure that we're screening them every 72 hours if we're going to give other products to make sure that that blood that we're giving them is appropriate and compatible with them and they haven't developed any other antibodies. So how long is a cross-match eligible if a patient never received a blood transfusion before? So if it is an outpatient, that cross-match is valid for a year. If it's an inpatient, it's only valid for their stay. But a cross-match would only be done if the patient is requiring any blood products at that point. Great questions, everyone. Is there anything else? Oh, perfect. Thank you, everyone. Have a good day.
All right, everybody. Our last topic for the afternoon is medication safety. And here with me is Derek Lee. He's a nurse educator for the med safety team. And he's going to talk to us about what we do here at PHC in regards to med safety.
Perfect. Welcome, everyone. I know it's been a very, very long day, so just sit back, relax. Don't worry about memorizing everything, because everything that I'm going to be talking about this afternoon is all on Connect. So just take in what you can, okay? Okay, first off, the team. So at Providence Healthcare, this is our team. We have Isabel Diogo, who is my boss, the practice consultant. You have myself, and I work alongside Courtney Symes, another nurse educator working in the same portfolio. Also, we work closely with Astrid Westerveld, who's also a practice consultant. She handles everything to do with policies and standards of practice. So any of the documents, she has a handle in it. So PHC is a learning organization, so we always value everyone's contribution. So please, if you're interested in promoting a culture of medication safety, there are various venues that you can actually contribute to. So the first one is, I'm sure you've all heard of the PSLS, so the Patient Safety Learning System. So reporting events such as near misses and good catches. So with regards to PSLSs, it doesn't mean that an error has occurred, an error has already occurred. If you've caught an error before it happened, please complete a PSLS. Having conversations. So this is about informal and formal conversations. So say you have a lull in time and you're talking with your colleague and you're saying, why can't we do this better? Why are we doing it this way? Please ask questions, and so that we can give you the provided information, because you never know, you might be the first one to ask that question. Participating in the Pharmacy Nursing Committee, where you can submit an SBAR for any of your ideas. So it's like, what if we do it this way? Can we do it this way? What are your thoughts? And you put that forward and talk to your nurse educators and your clinical nurse leaders and submit that idea. Keeping up on newsletters, and practice pointers, practice alerts, and safety huddles, which I'll talk about later and show you where they are all located. But these are monthly newsletters and pamphlets to showcase what we do in the medication safety portfolio. Joining the Nursing Practice Council, where we share our ideas about what's new, what's upcoming, and what's happening, so to keep you in the loop. We will be reviewing some of each of these controls today, so don't feel like you need to memorize everything. You can always ask for clarifications and refer to policies and procedures. But essentially, this is what governs our practice, which I'll show you next. So, safe medication administration is a top priority in healthcare today. So, at PHC, our practices are informed by our various governing bodies such as the Government of Canada. So this is our Ministry of Health, which has the Controlled Drugs and Substances Act, which states that hospitals must maintain accurate and up-to-date records and to secure storage of narcotics and controlled drugs. And then we have our Accreditation Canada, which states to meet standards, hospitals must have policies and procedures in place for high alert medications and are recommended to segregate and provide directed access to reduce selection errors. And our own college states that nurses are expected to be accountable to ensure safe storage of medications, document accurately, and resolve discrepancies as soon as possible. And at the local level, we have our own medication policies, which states that storage of all narcotics and controlled drugs must be secured using a locked vault or an automated dispensing cabinet, also known as an ADC. So access to these equipment must be limited by locks and keys or user IDs and passwords. So we just had our last accreditation 1 month ago. So we won't be having we won't be surveyed for another 3 to 4 years, depending on our results. So you're going to hear about required organizational practices, also known as ROPs. So what are ROPs? They're essential practices to enhance safety and minimize risks. So you'll see on the screen, we have 7 standards under the medication portfolio, but we'll only be talking about the 2 highlighted, 2 bolded one you can see on the screen, and we'll touch upon the bottom half as well. So the first one is high alert medication policy. The ROP states that the strategies for minimum safety activities for storage, prescribing, preparation, and administration includes power plans, patient-specific labels, alerts in the Omnicell, alerts in Cerner, a ready-to-use formats when provided when possible. They will have a drug entry in the smart pump. They will have a PDTM monograph, which I'll show you later, as well as requiring an independent double check. So what is a high alert medication? So first off, high alert medications have an increased risk of causing significant client harm when they are administered in error. So you can see on the screen here, this is one of our medication safety huddle sheets highlighting the high alert medication policy. And within it, you'll see a table of all medications and routes. Do note, you don't have to memorize the list by any means. We do have a policy in place, and it can be found in SHOP as well. So an example of a high alert medication is methadone. So 10-fold errors have occurred, resulting in patient harm. Investigation of these events have revealed that independent double checks have not been completed or were improperly completed. Methadone is frequently used at PHC for patient populations that we serve, both for substance use disorders and chronic pain issues here. This is one of our medication safety practice pointers regarding independent double checks. So what is an independent double check? It's when 2 clinicians who work separately to verify the accuracy of the order and medication to be administered. So the clinician performs a verification process independent of one another and without knowledge of the steps followed or conclusions arrived at by each other. So results are compared and discrepancies, if any, are addressed before the medication is administered. So this is not to be confused with a double check. An independent double check works independent from one another, whereas a double check is, hey, you're saying, hey, you know, you and your colleague are working one night and you work together and go, hey, you know, I can't figure out this calculation. Can you help work this out with me? So that's a double check. Whereas an independent double check, you're figuring out the calculations by yourself and your colleague will figure out them themselves. And then you work together to see if the conclusions you arrived match each other. So how do clinicians document an IDC? Within the charting for window in Cerner, there is a witness by field where you can enter their credentials. So how do you know a medication requires an independent double check? There are many alerts in place. So one of them is within the Omnicell. If you try to access the medication within the Omnicell, the ADC, you will have a pop-up alert. as well as you can also check the medication product note. As you can see on the bottom right-hand corner, there's a symbol that looks like a Post-it mark. And so if you click into that, it'll show you that says independent double check. We do have a guideline in place that is specific to Providence Healthcare. So just make note that when you do search for the guideline that you pick PHC, because there's one specific to VCH as well. We're aware that the topic of hazardous drugs were covered comprehensively earlier in the week, but wanted to remind all of you to look closely on the product notes and alerts in the system to let you know which medications are deemed hazardous. So you can see that it will show up on the order comment. It will show up on the banner bar for hazardous drug group 1, only because it has a precautionary period. You'll see alerts in the Omnicell. You'll see alerts within the MAR as well. You'll see a blue hazardous drug alert there, and also on the actual product itself. So you can see on the bottom of the screen there, it can be on multi-dose packs. It will be on any pharmacy-generated medication and labels. Most of our documents, including safe work procedures and control matrix surrounding hazardous drugs, can be found on Shop there. So just as a reminder that these safe work procedures are to be used anytime preparation of a hazardous drug is required. Take a look at them when you get a chance, and speak to your nurse educators for more information, really. We have a practice pointer specific to hazardous drug resources with hyperlinks. So this is your one-stop shop regarding hazardous drugs. All the information there is embedded. So if you're wondering where this and that are, you can find this practice pointer and it'll link you to all the appropriate areas there. Cerner, just like many electronic system, has downtime, so both scheduled and unplanned. So there are processes in place for when these occurrences happen to help you when these occurrences happen. So in each area, there is a designated 724 downtime computer, and it will have a label, as you can see on the screen, it's yellow, and it'll have the sticker in place. So this downtime computer is very, very important to note, because in the event that there's a downtime, this is the only available computer that will have up-to-date patient information. So this is hardwired and into the system so that information is updated every 2 minutes. You can also see on the screen that there are tons of resources within Shop. So when you get a chance, please take a look at it, because you never know when your downtime can happen. It can happen on your first guided bedside shifts or your first solo shift alone. So it's a good idea to know where these resources are available so that you know what to do. PHC supports the Do Not Use list of abbreviations adopted by the Institute for Safe Medication Practices. If you see any of these abbreviations, symbols, and dose designations anywhere, please let someone know. Please speak with your nurse educators, your clinical nurse leaders, because nowhere in any part of documentation should they have any of these embedded, because having any of these can increase the risk of error. So although in Cerner we have everything we have drop downs, we have everything kind of pre-printed or everything embedded, but there are areas where there are free text options available and free text fields. So if you see any, please speak with the provider or whoever put in that order for order clarification, and to let your educator or CNL know so that we can correct it in the system if needs be. So there are two components to medication reconciliation. So the first part is the best possible medication history. So this is also known as the BPMH, and it is within the scope of nursing, pharmacy, and providers. But mind you, within the scope of nursing, it's only in certain areas, which are the surgical daycare, pre-admission clinic, and areas with direct admissions. Accuracy and validation with two sources of information is important. So if you think about it this way, imagine you come into the ED department and you have this patient you've never seen before getting triaged, and you're they pop up the information from PharmaNet, which is all the medication they're taking in the community. But what that list only shows is only maybe 70% of what they're actually taking. You don't know what they're actually taking at home. The system may say one thing, but what the patient actually takes at home may be different. So the BPMH is really to go through with that patient saying like, hey, you know, is this what you're actually taking in the community or at home? Then the next step is the medication reconciliation. So this must be done only by providers, and it generates the medication orders. So once the BPMH is done, the provider will talk with will consult with the leads with whatever team they need to, and with the patient, and say, you know, this is what you're taking at home, but this is what you're taking while you're in the stay of the hospital. Transfer medication reconciliation is also completed at transition level. So if the person is transferred from ED to an inpatient, that must be completed. If the person is being transferred from, say, a medicine to surgery, it must be completed. From surgery to critical care, anytime you transfer between different programs, a transfer medrec must also be completed. So an accurate and complete allergy information history must be present and verified prior to prescribing, dispensing, or administering any medications or non-medications, except in emergent situations when history is designated as unable to obtain. So there is a hard stop within Cerner, so it won't allow you to actually process any orders until the allergy information is actually inputted, which is a good thing because you don't want to accidentally order something and you actually bypass and you can cause an anaphylactic reaction. So if not already completed, nurses are responsible for documenting the allergy status. So you can see on the screen. So within Cerner, there is on the banner bar, there is an allergy status, as you can see on the bottom of the screen there. Click into that and you'll get another screen, and there's an add button to input whatever information is necessary and appropriate. So the gold rule is orders must be placed by computerized provider order entry, also known as CPOE. There are exceptions, and it's stated as follows. So exception is for verbal orders are only to be used in emergent or procedural situations. So if there's a code situation, you're not going to get the provider to go into Cerner and input that order manually. Telephone orders are only acceptable when the medication is urgently needed and where it is not practical for the prescriber to electronically enter the order directly. So the person might be in a sterile field and they're unable to reach, they can't type it in. They can only give you a telephone order. So there is a policy in place that states this as well. So please, if any kind of prescriber all of a sudden gives you a verbal or telephone order which doesn't meet these criteria, please reject it. The order priorities, please note that we do have a policy in place where when the order is inputted, if you order something stat, the medication should come to you within 15 minutes. And if it doesn't, please connect with pharmacy and go follow up with what happened. A now order will have less than 60 minutes, and a routine is at the next scheduled dosing time. So this is what when you're ordering what it looks like here. So by choosing phone or verbal as a communication type, a co-signature request will be sent to the provider. No co-signature required may be used for certain nurse-initiated orders, such as if you need to put in a referral to wound care or for the IV team. And co-signatures required paper, fax, and electronics are not to be used. So one thing to note, if you do put in a verbal or telephone order, it can be enacted right away. So that's why we have a policy in place that states the provider must be with you throughout the duration of the order entry. So from the point of you speaking with them and you're typing everything in, until you hit sign, the provider must be on the line or speaking directly with you, because there could be alerts that pop up and it must be addressed by the provider. Here is another practice pointer specific for verbal and telephone orders. Another thing to note about verbal or telephone orders if you're entering in by the clinician is to be mindful about the next administration time. You may need to adjust the first administration time depending on what is appropriate to the clinical indication. So for example, on the very bottom of the screen, we gave an example about Ramipril 2.5 milligram was given at 11:17 hours from a previous order. Then at just after noon, a new order for Ramipril 2.5 milligram BID was placed. So the start date time was not adjusted when a new order was placed. So medication test appeared on the MAR less than an hour after a dose was given. To remove the duplicate test, simply right-click and select Chart Not Done, Task Duplication. But we've had many, many PSLSs where, for whatever reason, a double dose occurred because they saw, clinician go, oh, I saw this, I gave this, could be another clinician that went on break and someone's covering and, they didn't see an alert in place and they accidentally gave a double dose. So just be mindful of when you're putting in these orders. You're going to hear closed loop medication management quite a lot, at least from the med safety portfolio, because this is your gold standard. This is the process that limits the risk of medication errors. So CLMM always starts by CPOE. So the provider puts in the order into Cerner, then the pharmacy will review, then the nurse will review the order, and then comes the medication preparation. So note that parenteral and bulk liquid oral items must be scanned at the Omnicell for a barcode to print on the Omnicell label. So make sure you keep all the labels and barcodes, all the packages, because anything to do with the barcode, you need to scan it later on. So after you complete your medication preparation, you go to your patient at the bedside, you barcode scan the patient ID or photo ID sheet, and then you barcode scan the medication, then you administer the medication, and then you document the medication administration. So this is closed loop medication management. So when we're talking about labels and barcodes, please note that there are various labels there you can see on the screen there. Some of them are linear, some of them are QR, some of them are 2D, and what have you kind of thing. So just note that, whatever you scan, ideally it should be any of the pharmacy generated label, but for any reason, if you scan a medication, the barcode on the medication, and you get an alert in Cerner or something, you get an alert that says, something's off, please pay close attention to it and connect with pharmacy if you need to say, hey, I'm getting this alert in place. Like, is this the right medication? It looks the same, but it's not, the scanning is not picking it up for whatever reason. So please connect with pharmacy to ensure everything is correct. This is just another practice pointer regarding the Omnicell barcode scanner. So at the ADC, like any other technology, it can fail for whatever reason, really. So the scanner is not working. Try scanning the item leaving the scanner so that it's in its cradle, but most of these now are already in this cradle, and you can actually scan the medication on its side kind of thing. So sometimes, for whatever reason, the actual label gets cut off. So if there's a letter missing, if there's something faded and it doesn't pick up, reprint the label if you need to. There's an option within the ADC to reprint any label. But this, I won't go through everything, but just note that we do have a practice pointer and there are ways to mitigate any of the issues that may occur. We've had a lot of questions brought to us about what the different functions are within the MAR task. So when you enter the MAR and you right click on a medication, there are various selections you can choose, and choosing the appropriate one will inform what your intentions are. For instance, when you click on rescheduling this dose, it moves the medication task to a later time so that you will be tasked with that. Your clinician will actually see it tasked. So for instance, here is that if the person is nauseated and they're saying like, oh, what, give me half an hour and I'll take the medication kind of thing. So you might want to reschedule this task. So if you click not given via the MA or versus the charting window, so this is, you will drop off the task entirely. So this is what you want when the person is just completely refusing or declining the medication. They're saying like, nope, not happening. I'm not going to take it. Then by all means, click not given so you won't get tasked again. Charting not done. This is primarily done when there's a duplicate task. Modifying an order. So you should only really be modifying an order post in administration, primarily for range orders or for an IDC. For range order, for instance, we have the Tylenol here. Yeah, you brought in 2 325 milligram tablets, and all of a sudden the client is saying, no, you know what? I'll just have 1 tablet for now. So you'd have to go back and modify the order so you chart appropriately. Uncharting, that functionality is only if you chart on the wrong medication or the wrong person, and so you have to go back. Additional dose, so if the medication has not been given, is due, and no medication task exists on the MAR. So the example here, so if there's an order for ASA 81 milligram, PO daily does not have a medication task on the MAR for 0800, the task may have been used to document administration on a previous day. So yeah, if you know a medication is, say, even a multivitamin, and you know it's being as an order for a daily administration, but you don't see a task with it, then you know you will have to generate that additional dose to get that task. So the best practice is to scan each patient's wristband for patient verification. However, there can be instances where this practice may not be possible. So for instance, the person may be too edematous. The person may have a clinical indication that doesn't allow them. The person maybe have insufficient limbs. So for whatever reason, in these cases, there's a protocol in shop to mitigate this. And you'd have to use a PHC approved device to take a photo of the patient and then print it off to have a FormFast ID. But don't need to memorize it. Just know that for whatever reason you can't affix a wristband, that there is a protocol in place. For those of you who have not seen what the MDCs looks like, so this is an MDC, a medication delivery cart, not to be confused with the workstations on wheels, also known as the WOW. So here, I'll work on the top left, going around clockwise here. We have a tap and go using your ID, so you don't have to manually type in your username and password every single time. We have the 3 batteries that has 8 hours of power. Of course, we have the monitor that can go up and down and swivel left and right. So just keep note that if you're going down the hallway or going, if you're mobile with your MDCs, please shift the screen to the side just so that you can look forward so you don't bash into anything. It occurs more often than you think. We have your hand sanitizer, your keyboard and mouse. And here's where the difference is between an MDC and a workstations on wheels. On our MDC, we have 6 dedicated medication preparation, 6 patient medication drawers, and on the bottom we have the medication preparation supply drawer. The patient medication drawers require a PIN, whereas the bottom one does not. And of course, we have the barcode scanner on the side. In terms of cleaning, please make sure that all surfaces except for the screens, you use the Caddy wipe or the Excel intervention wipes. And then for the screens itself, use the Kimtech wipes or the ProSep wipes. So now during your unit-specific orientation, you will all receive training on how to use the ADC for medication administration. So to set you up for success, we just want to take a few minutes to talk about best practices regarding Omnicell. So one patient at a time, don't want to stress that enough. Please try to take out multiple medications for multiple patients because that's when errors occur. And always refer to your patient's MAR at the Omnicell. Adjacent to each Omnicell should have a working computer, so please utilize that as your source of truth. Remove only what is ordered for the specified administration time. Never remove more meds than are ordered for the specified administration time. So we know there are medications that are around the clock, like Tylenol, and so all the puffers and inhalants and things like that are Q4, and it's very, very easy for the clinicians to yank out a day's worth. And there are multiple problems with that. And one of them is just plain patient safety because you don't know what is actually you're taking out and how much you're actually going to be in stock. The second is that by removing what more than is intended, the actual ADC equipment will not recognize that it needs to be refilled, because there's a different threshold within each ADC, and if you don't reach that threshold, pharmacy doesn't know when to replenish the medication. Barcode scanning is required for removal of all parenteral and bulk oral liquid medications, as said before, because you need that pharmacy-generated label for the barcode. Wait for labels to spit out, so please don't yank on the label. We know there's a delay in a second when it's printing, so just take that half a second for it to completely spit out, and then you can rip it and tear it away. Ensure the printed label is legible and not missing any pertinent patient information. And like I said before, you can always reprint it. If there's any kind of errors, any smudges, anything missing, just click on the function of reprint the labels and you'll get another one there. So only bypass this function if it is an emergency situation. Barcode will not scan, there's no barcode, or the scanner is not working. So if you run into any problems with the Omnicell, know that there's an Omnicell administrator to help you navigate these issues. So call pharmacy and say, I'm having some issues. Can I speak with the Omnicell administrator, please? So there are two different kind of labels. There's one for the one on the left here. You can see this is label. So this is your pharmacy generated labels. And on the right hand side, you'll see the receipt paper for discrepancies. So if you haven't had a chance to replenish these before, know that you will need to learn how to. So speak with your nurse educator, your unit nurse educator, and your CNL to learn more on how to work through this. Only access cabinets in your practice area. So if you need if you're working on surgery, don't go down to renal. If you're on medicine, don't go down to cardiac to yank medications, because that's where errors can occur. Always log out after use by touching the exit sign after using the system to ensure your access is secured. Because if you do not press that exit functionality, anyone can use your credentials to pull out medications. Omnicell cleaning, we talked about the MDC, is very, very similar. Any metal surfaces, use the Excel intervention wipes. And for anything that's like the screen base, you're to use the Kimtech and ProSet wipes. So cleaning and disinfection is a two-step process. There's the rub action, and then there's actually the cleaning process. There is a dwell time in the middle, so depending on the product used. So just keep note that you can only imagine how many clinicians actually use these devices, so you may want to clean them. Remembering to count back. We want to emphasize how important it is to count back for all narcotic medications. The count back needs to be done before any medications are removed from the bin. So if it's not done properly, this could create discrepancies. And we always say we always count with your hands open, is because very, very often that we're always in a rush and we want to open the bin and just yank out our medications and then, confirm everything on the screen without actually counting what's in your hand. Now, along with general best practices, we want to highlight some best practices specific to narcotics. So count correct liquid narcotics only at the end of each bottle. Liquid narcotics should only be count corrected at the end of each bottle, only because we cannot count on the gradients on the bottles. Don't use, if you see any tape with numbering on it, please disregard that. So only count at the end of each bottle for liquid narcotics. If there is a discrepancy of greater than 10% at the end of each bottle, then the narcotic incident report must be filled out. So don't worry, it's not a one-person thing. If you need help with it, please contact pharmacy, your nurse educator, your CNLs to work through that. Making sure you resolve all narcotic discrepancies and reconcile all partial doses ASAP and before end of shift. Like I said before, if you need help, talk to your leaders and pharmacy. For discrepancies which cannot be resolved, the narcotic and controlled drug incident report must be completed. The guided cycle count, it must be done weekly. for each OmniCell in your area. So some OmniCells have one, some areas have one, some areas have 2, 3. And each one of them must be completed by 2 nurses. And it's usually designated on the Sunday. It takes roughly about 10 minutes to complete in each ADC. It gets faster every single time because some OmniCells have more narcotics than others. So just make sure you you clear any discrepancies by completing an open cycle count and verify what's actually in the bin. So how do you communicate with pharmacy? There are multiple ways. The most common one is a medication request. Note that there are 2 ways to access a medication request. On the menu, there's a button there, as well as on the MAR, you can right-click the medication, and there's a med request button there. A couple of things to note here is that just because you make a medication request does not necessarily mean pharmacy will grant it to you. There may be many, many reasons why they will not provide you the medication, such as maybe it's already ward stocked on your unit, or perhaps there is another reason down the line that we're not aware of. So within the medication request, when you go to that page, there is a history button that can tell you the status. So if you're wondering like, oh, I sent this up, 30 minutes ago, how come I'm not receiving this medication? Look at the history to see what the status is. Every area, every program has their own clinical pharmacist. We have a dispensary pharmacist coordinator. We also have an on-call pharmacist at nighttime. So note that, say it's a long weekend, it's midnight, you have this new medication, you don't know what to do with it, and you need to speak with the pharmacist, please make sure you reach out to the pharmacist on call by contacting the dispensary here at St. Paul's. So any other areas can utilize this, but you have to call the St. Paul's Pharmacy to speak with the on-call pharmacist. And as I mentioned before, we have a dedicated OmniCell administrator for any ADC-related concerns. So how do you reach all of our medication resources? Within the main page on Connect, I need to update this. Unfortunately, there's a new change as of yesterday because it's no longer this bright red. It's like a teal and a blue layout, but essentially the medication resources page is right under the clinical services and support. There's actually a new button there that links you to the medication resources page. So within the medication resources page, you can see on the right-hand side of the screen there's a ton of practice pointers and alerts and things like that. So before you have any questions about how to work things out, please have a look at it because that may actually guide you to your answer already. The snippet there is just 1/4 of a page there, so just note that there's a lot of resources available to help you. And of course, if you find a broken link, please let your educators know or let someone know so that we can update it on our end. Here are some additional resources found under the nursing tab, including the Shared Health Organizations portal, the shop. So here you'll find all the policies, standards of practice, guidelines, what have you, everything is found there. We also have the PDTM, we have the Elsevier clinical skills. So if you're wondering, how do I insert a subcutaneous butterfly? Take a look at there and you'll find the answer there. Lexicomp, if you need some information to provide to your clients and their families. Up to date, if you're looking for journal articles say, on any topic, have a look there. Learning Hub courses, and of course, Care Connection, that's where the latest versions are. So let's talk about the PDTM. So the PDTM is a parenteral drug therapy manual, contains parental monographs that will help identify how the medication is to be stored, supplied, and administered, amongst other information. So the PDTM also has information on ID compatibility, but you can see it's on the side. It's on the menu side there. You'll see the ID compatibility, the PDTM client monitoring levels, and the site-specific administration restrictions. So this is an example of the site-specific administration restrictions for PHC. So when you click on the site restriction, there are multiple areas. Please click and ensure you're on the PHC specific one. So for instance, if we look at Alteplase and you have an order for IV direct Alteplase, well, it can only be administered in critical care areas. CST Cerner helps. So if we know that navigating Cerner is very, very challenging, and so to help you on how to go through the step-by-step process, you go to Clinical Tools, and there is a CST Cerner Help button there. Click on the search button. So how do I administer a medication? How do I remove a duplicate order? Type that in, and it'll give you a step-by-step workflow on how to go through that. Last but not least, we want to hear from you. So you will be receiving a survey from me approximately a month from now regarding your experience surrounding Cerner functionality and workflows. So it takes about 10 minutes to complete. Your feedback is vital. I mean, enough is said because we can't improve unless we hear from you. So please don't treat it as junk in your mail inbox, please. All right, let's see. We have some questions here. All right. First question, what can you use to scan the patient barcode? Patient addressograph on the chartlet, patient ID band, photo ID sheet, 2 and 3, which is a patient ID band and photo ID sheet, or all of the above? Take a wild stab. Don't worry, your answers are anonymous to me, so I can't see what you're answering. Okay. All righty. And the answer is 2 and 3. And the reason why it's not all of the above is because we no longer have a patient addressograph. We've discontinued that a while back. So if you see any around, that's interesting in one way, but we shouldn't be seeing them anywhere. So the answer is patient ID band and the photo ID sheet. All right, the next question is, for what reason should I complete a PSLS report? A near miss when you almost gave hydralazine instead of hydrochlorothiazide. You gave the patient their Lasix IV instead of PO, but it was still the right medication. The patient received methadone at 10 times intended dose, or the dose of the medication on the MAR does not match the prescriber's order, or all of the above. We'll give it a few more seconds here. And the answer is all of the above. Perfect. So yes, so a PSLS does not mean the error have occurred already. So what we say, a near miss. So if you catch a mistake early on before it happens, by all means, please complete a PSLS. And truly, it is not a blame game. It's to see really where can we fix the error. Many of the times we know that there are system errors in place. So how can we fix the system error? And many times we look back and we look at these root of the problems and we go, oh, no wonder why the clinicians, or something, or provider, or someone made a mistake because the system in place did not support the clinician. So please complete those PSLSs. All right, let's see what the next question is. Next question is, which medication requires an independent double check? Methadone oral liquid, subcutaneous insulin, IV furosemide, oral liquid hydromorphone. Yeah. All right. And the answer is methadone oral liquid. And I know Carrie Ann's gonna hears me every month about this, but I'm very curious to hear whoever answered subcutaneous insulin where you came from or where you do this, because we hear a lot that this comes from from a school kind of basis, whereas as a student we know that they get everyone to double check their insulins and ensure all the units are accounted for. So, or if they're up north, I know that they do it, and even out east. But I'd be curious if you can type in any information that you're willing to share with everyone. But the correct answer is for PHC that methadone oral liquid requires an independent double check. Last but not least, welcome to Providence. Please, if you have any questions, I'm happy to answer anything. And of course, if you don't have any questions as well, that's also fine. And you can always reach out to us. But let's see if you have any questions here.
Somebody answered your question.
Oh, or is it back on this one? No. Let's see. We needed a second nurse to co-sign any insulin administration in hospital in Ontario. Oh, okay, Ontario. Actually, I don't think I've heard about Ontario. I've heard, I think, even like Nova Scotia and out east that way, but even in Ontario. Okay. One thing to note about independent double checks and double checks, there is, what is the IDC procedure? Where can we locate it? The IDC procedure, the whole guideline can be found on SHOP, and it will tell you explicitly what the step-by-step processes are and actually how to document it and so forth. We also have a practice pointer and a medication safety huddle sheet that is found on the medication resources page as well. And so, mind you, that asking for a double check can be done for any medication as well. So if you have a really, really bizarre order of, say you have, so even though subcutaneous insulin, it does not require an independent double check, it does not mean that you cannot ask for one. Because sometimes you may get a really, really bizarre order that you may have not come across. And it's good to, speak, connect with your colleague and go, hey, Derek, I got this order for, 300 units of insulin R, but something seems off. By all means, question it and speak to your colleague and, be confident in what you're doing. Any other questions? All right, none at this point. By all means, please speak with your nurse educators and your CNLs and bring up those questions if you have them. You may be the first. Thanks, everyone.